You cannot stop atherosclerosis, and your patient will probably be a member of the placebo group and be under the tube. But then, of course, the next question is, why are we so aggressive? How can we stop the train? Because you see now a picture of severe atherosclerosis on the left and a native aorta with the intercostal arteries coming off that are the holes. First of all, we don't want to have the atherosclerosis as depicted, but we also would like to, at least in part, to reverse it. So how do we do that then? How do we stop this train? Can we actually do that? Can we go that low? And then, of course, you all know statins do lower LDL cholesterol, but if you really want to stop progression, or even if you want to go to a slight amount of regression, that is possible. But then you need profound LDL lowering of at least 50% and probably even more. You should go around 75%. So that's a lot. And this is coming from invasive data from an important study. This was comparing pravastatin with atorvastatin with an IVUS trial. And then we see that you can only be at the 0 line, so no progression anymore, if you have at least 55% of LDL lowering. So we should be over 55% to stop the train. And that's not easy. This is what statins can do. You see the dotted line. Only with rosuvastatin you can pass this threshold. Even with atorva 80 you cannot be there. And the combination, of course, of a statin with ezetimibe can also do the trick. So we had statins. You can reach around the 50% at max. And then we did the Improve It trial, and I was a part of it a long time ago, where you add ezetimibe on top of a statin. Instead of doubling the statin dose, where you have only 6% of LDL lowering, now you have 20%. And yes, also a non-statin could do the trick. A non-statin was also advantageous for you to more lower, because here in this trial, on average, your cholesterol was lowered from 1.8 millimoles per liter to 1.4 in the ezetimibe group. So going from 1.8 to 1.4 was clearly beneficial. And the next thing was, of course, you know that some patients cannot tolerate statins mostly because of the muscle complaints. The true estimate of muscle complaints is around 10% of your patients. And now we have, of course, bempedoic acid. And it's in the same pathway as a statin, but it doesn't work halfway where the HMG-CoA reductase is, but it's at the top. It's in the same biosynthesis pathway. But it targets ATP citrate lyase. This is an enzyme upstream of HMG-CoA reductase. Finally, it's giving you the same effect because it's upregulating LDL receptors. But the nice thing about bempedoic acid is that it's a prodrug, and the specific isoenzyme which converts bempedoic acids into the active CoA form is not present in the skeletal muscle, so therefore it's supposed to give far more muscle complaints than the statins actually do. And actually, last year, this is the New Impact publication of last year, the Clear Outcome study came out where it was shown that in statin-intolerant patients, indeed, all the coronary endpoints were reduced by bempedoic acid, as you can see over here. And the side effects were relatively minor, especially relatively few muscle disorders, not more than placebo, but there was some more gout and cholelithiasis. So we have another trick, because many patients will not reach your 1.4 goal. And if you really want to stop the train, you should be there. So you should not be at 2, you should not be at 1.8, you should be below 1.4, below even 1 perhaps. And we can now do that with the pro-protein convertase subtissular caxin type 9, the PCSK9 inhibitors. So if you really start with the high cholesterol, there is no other way you can come there. And if you know how they work, you know your LDL particles giving you the atherosclerosis will normally go into the liver cell by the LDL receptor. And then the LDL particle is degraded, but the receptor is cycled back to the surface of the liver cell, which of course is very important to catch your new particle. However, this is regulated by a protein called PCSK9, and if this combines with the LDL particle and the receptor, the entire system is degraded. So the receptor is not recycled, so too much PCSK9 leads to too few receptors. And too few receptors leads to too high cholesterol. And then we try to interfere with PCSK9, and that appeared to be very difficult. So we had lots of small molecules which were not helpful. And finally, we came up with antibodies. They make a complex with PCSK9, so it cannot bind to the LDL particle receptor complex. You say, okay, this is a very nice idea, but does it actually work? Yeah, it works. If you give evolocumab or atherosclerotic on top of a statin, you do not have 6%. That's a doubling of the statin dose. You do not have 20%, like ezetimibe does. You have a 60% additional LDL cholesterol. So now we're talking business. And you see the two trials here depicted in one slide. The one was in the stable atherosclerosis patients, the Fourier theory, where you have a 15 to 20% MACE reduction. And the other one that I was co-designing and published in the New England was the Odyssey outcomes. That was the acute coronary syndrome study. So all patients had atherosclerosis, and there you see a MACE reduction, non-fatal and fatal events, and all-cause death was even reduced. So these injections you need to give every 2 weeks or every month subcutaneously. And then you could argue, can we do it even more efficient with less injections? And now we have, of course, as you know, the siRNA therapy. I will not go into detail because I have a lack of time how it works. But it's a synthetic RNA molecule which finally inhibits PCSK9 synthesis in the liver. So you're not blocking it in the bloodstream, like the atherosclerotic does. This is inhibiting synthesis in the liver. And in phase 1 studies, it lowered your LDL cholesterol around 50%. And after an induction phase of 0 and 3 months, you only need 2 injections per year. And it gives you an LDL reduction of around 50%. And then you say, okay, now show me also the outcome data like I did for the antibody trials. They're not there yet. You have to wait because on the outcome data, there's the Orion 4 trial in the US and in the UK and the Victorion 2 prevention trial where I'm part of. And they are still going on around the world. And then you say, okay, let me see, you're talking about some kind of lifelong therapy. Can we do even better with gene editing? And I'll only give you one short example of a glance of the future, how to stop the train. And this is this large part. Gene editing is now coming up. I will not spend words of it. If you have questions about it, I will be happy to answer. But this is about vaccination. If this PCSK9 is so efficient, if you block it to halt the train and to stop progression, why don't we vaccinate against PCSK9? And well, perhaps we can then stay together. Since you are as old as your blood vessels are, we can stay forever young. And actually, this is not utopia. We tried in our department, we have also a transgenic mouse department. These mice have human genes in it, so they get human-like atherosclerosis. We tested many compounds and we published them. And this is what we published in the European Heart Journal a couple of years ago, where we actually vaccinated the mice against PCSK9. And then you say, okay, does it work? Yeah, you can see this as you can see over here on the left panel. You see atherosclerosis in the mouse. And this is like human atherosclerosis. You cannot distinguish it for human atherosclerosis. And you see the black arrows, it's full of atherosclerosis. You see the foam cells. And on the right side is the vaccinated mice. And actually, they just have a vessel wall with almost no atherosclerosis, although they are on a Western type diet. So perhaps vaccination against PCSK9 or other vaccinations is feasible. So, Mr. Chairman, to conclude, how to stop the train from progression, you really should do, apart from the acute PCIs, which are very useful, and the rest of the topic is about more invasive cardiology for the following speakers, but how should we stop the train? A profound LDL lowering then is necessary. So I hope you're not too tired, because talking of cholesterol should not be tiring to you and should not be tiring to you, to your patients. We should stop the train by profound cholesterol lowering. And how do we do this? This is my final slide. We do this with, as you know, with statins. If it's not sufficient or they cannot be tolerated, ezetimibe and bempedoic acid. And on top of that, profound LDL lowering can be reached by PCSK9 inhibitors and perhaps in the future vaccination of gene editing. Thank you for your attention.
Thank you very much, Professor Jokime, for this excellent presentation. I just talked to my friend, Professor Dr. Wael Kilani, that such elegant and illustrative presentations, it's shame that we don't have a full room to hear such presentation. But anyway, it's very early in the morning. However, we have recorded this presentation, so we're gonna put it on our YouTube channel of the society so everybody can hear it. Thank you for the elegant presentation. And I have a comment, then just a question, small question. The comment that it's not only LDL and the cholesterol which can prevent the train from reaching the final station, but also tackling all risk factors like hypertension, diabetes, smoking, all other risk factors which help the patients with ischemic heart disease from reaching this final destination. My question for you, I think it's now clear that bempedoic acid should be before PCSK9 inhibitors in the guidelines. However, in the guidelines, it's high dose statin, high intensity statin, ezetimibe, and then PCSK9 inhibitor. Today, you put the bempedoic acid before PCSK9 inhibitors. If this is okay on clinical basis, the final point that off-label in the administration of PCSK9 inhibitors, when we give it on the, as they said, every 6 months after the initiation, we found that some patients, they have very, very low LDL. Can we expand it to some patients again? Are you gonna postpone it like 2 months more or 3 months more, etc.? Thank you very much.
Excellent remarks. Of course, there's more than cholesterol. All the risk factors are important, especially smoking, of course. I completely agree. And then we are arguing how low should your LDL be. And in the Odyssey outcomes trials, we had a safety measure that if your LDL cholesterol was below 0.5, so very low. So we had a measure that we should stop the drug for a moment, and if it remained below 0.5, it was even stopped during the whole trial. And then we looked how these patients actually did. And then these very low LDL patients, they did excellent. So virtually every cell in your body can manage and produce its own cholesterol. So what you have in the blood is probably for the most part is not necessary. It's only the transportation system. And if you have too much of it, it will just hamper your blood vessels. So an LDL of probably 0.5 is more than enough. These patients were doing excellent. We had patients that had 0 cholesterol in our trial, and we followed them up for over 5 years. And they did extremely well, and they had very, very, very low event rates. So we should not be afraid probably with PCSK9 inhibitors if you induce LDL cholesterols that are very, very low.
But sir, you do not recommend more spacing of the dosing of PCSK9 inhibitors, no, or it's not studied? No, so
if you space it more than every 2 weeks or every month, then you get this tooth thaw phenomenon that it's higher, a little bit lower,
so there is more fluctuation,
lower. And there is little data if this is a good idea. Probably not. Probably it's better to have a certain level that's stable.
So if it's low, keep it low.
Keep it low, don't worry about it. And if your patient said, I have only my cholesterol is below 0, you say, congratulations, you stop the train.
Fine. Second question, commenting on what Dr. Islam said about putting bempedoic acid on top of high intensity statin and ezetimibe.
Yeah. In many countries, there's a debate if you should use bempedoic acid first, or the European guidelines do not say so. They say you can immediately switch to PCSK9 inhibitors because they are so much more efficient. Because also with bempedoic acid, you cannot reach more than, let's say, 34.
Because it's working on the same axis also. So does it make sense to put both on the same axis?
Yeah, a little bit. So on top of it, it helps a little bit extra. Personally, I would not do it because I think the incremental effect is small, and if you need something more, personally, I would go to PCSK9.
The idea is the price, of course.
Of course.
Okay.
Although the price is rapidly dropping, I must say, because in the old days it was thousands of euros per year. And in many European countries, they have negotiated with governments. So if the production goes up, the price goes automatically a lot down. So I think it's of course it's still much more expensive than a generic statin. But in many countries, bempedoic acid and PCSK9 inhibitors per year have the same price.
Okay, fine. One final question. I will take the chance being with us as an expert and ask maybe a silly question. In the past, we were told that decreasing LDL with statin is the best way for the pleiotropic effect. And now you are telling us data, and there are many data about decreasing LDL level is the issue. However, you can decrease it with statin, ezetimibe as a non-statin therapy, now bempedoic acid and PCSK9 inhibitors, and there are data about outcome. Do you think the pleiotropic effect of statin is not true?
That's an excellent question. Of course, the matter of pleiotropic affection is a difficult one. I do think that statins are very effective drugs. And apart from LDL, it's sure that you lower, for instance, CRP. So they have anti-inflammatory effects. So I think that's beyond any reasonable doubt. So we should be proud of our statin, and statin should really be the first step. If you can tolerate a statin, most people can. A lot of people have muscle complaints, but muscle complaints is also there in many people who do not take a statin. So I think true statin intolerance, it's estimated also from genetic point of view is around 10%. 90% can tolerate it. So you should start with a statin to have the LDL lowering effect about 30, 40, if you're lucky, 50%. Have the small amount of ancillary beneficial effects, and on top of that, do the rest. Okay.
Thank you very much. Pleasure. A valuable lecture. Thank you very much.
Thank you very much for inviting me.
Thank you very much, Professor Joachim, for this very excellent presentation. It's my pleasure to introduce my friend, Dr. Amir Khalifa from Asyut University. He's going to talk about invasive imaging modalities of atherosclerotic plaques, and then the non-invasive after the invasive. Dr. Amir.
Thank you, Mr. Chairman, for inviting me. I would like to thank the organizing committee for giving me the opportunity to share with you my lecture.
انت اللي invite us يا امير، انت اللي عازمنا مش احنا اللي عازمين.
ربنا يخليك. So my title will be Invasive Imaging Modalities for Atherosclerotic Plaques. Actually, the title was only mentioning OCT and near-infrared spectroscopy IVAS, NIAS IVAS. But maybe I'll explain it a little bit more. So I have nothing to disclose. This will be my agenda. Firstly, introduction and a short talk about atherosclerotic plaque formation and pathological features, different available invasive intracoronary imaging modalities, and this is what we will talk about. Namely IVAS, virtual histology IVAS, and NIAS IVAS, OCT, and coming soon the micro OCT. As we learned many times, atherosclerotic is the main pathologic mechanism of coronary artery disease and one of the main causes of cardiovascular related disease. Atherosclerotic coronary plaque progression and destabilization are responsible for the clinical manifestation of coronary artery disease, ranging from Crohn syndrome up to ACS and sudden cardiac death. Over the last few decades, intracoronary imaging modalities, IVAS and OCT and NIAS IVAS, also hybrid imaging modalities, developed significantly, giving us the opportunity to know the pathophysiologic mechanism of coronary artery disease, which is possible to study in the human coronary plaques in vivo and evaluate the prognostic relevance of different plaque types and microstructures. So how the plaque is formed? Shortly, it starts with the LDL deposition in the subendothelial space. Then macrophage migrate and phagocytose the oxidized LDL forming foam cells, which is apparently in the histology as fat streaks, followed by vascular smooth cells, which proliferate and cause pathological intimal thickening. Finally, vascular smooth cells dedifferentiate and apoptosis occurs, causing releasing the droplets of lipid and causing the lipid-rich core or necrotic core, as we can see. This schematic image of the atherosclerotic process from LDL starting up to the necrotic core. So what are the available imaging modalities? This is a comparison of different characteristics of the all available modalities: IVAS, radiofrequency IVAS, NIAS IVAS, and OCT. This is regarding the general characteristics about IVAS and radiofrequency IVAS using ultrasound waves, while NIAS using near infrared light and OCT using the infrared light. Regarding the spatial resolution, it is the highest for the OCT, reaching up to 10 micrometers, while it is around 80 to 120 for IVAS. Regarding the assessment of the native coronary plaques, a seroma volume could be assessed good with IVAS or radiofrequency IVAS, but not with OCT. Cap thickness is only available to be measured with OCT, and also the lipid core and necrotic core available by NIAS IVAS and OCT, while the microstructures regarding macrophage accumulation, neovascularization, and assessment of the lumen integrity only available by OCT. So now we will start with IVAS very shortly. IVAS was the first technique to introduce in the clinical setting more than 30 years ago, capable of in vivo imaging of the coronary arteries. IVAS uses sound probe located at the distal part of the catheter, emitting high frequency sound waves from 20 to 60 megahertz. Quantitative analysis of the ultrasound signals allow us to have a real-time monochrome cross-sectional image of the full circumference of the coronary artery wall. A major limitation of the IVAS lies in insufficient discrimination between the lipid and the fibrolytic plaques. It cannot differentiate between these kind of plaques, but it gives us a clear image of the lumen and the vessel area, as we will see now. How we can interpret the image: intima appears white, while media appears homogeneous black, and adventitia appears white again. As we can see on the left panel, it is the normal coronary artery, as we can see in IVAS, and on the right side is the atherosclerotic artery with black developed. So how we can differentiate the different kinds of plaques in IVAS? So lipid-rich lesion appears low echogenicity in contrast to reference adventitia. Fibrous plaque has intermediate echogenicity, while calcium has the highest echogenicity or acoustic shadowing. So lipid appears dark, fibrous appears a little bit bright, and calcium appears very white with acoustic shadowing, as you can see. This is the lipidic plaque, and this is a fibrous plaque, and this is a mixed with calcium and fibrous plaque. Basic IVAS plaque measurements: we can measure the lumen area, the external elastic membrane area, and by which we can calculate the plaque area, substituting the lumen area from external elastic membrane area, as we can see. Unfortunately, grayscale IVAS is of limited value. As we mentioned, it cannot differentiate between lipid and fibrolipidic. So this leads to the development of virtual histology IVAS. Virtual histology IVAS over the recent several years has developed the virtual histology IVAS developed by Volcano company. It has the possibility of differentiating the characteristics of the tissues and give us a color code mapping for the different plaque characteristics. So fibrous tissue assigned as a dark green, while fibrofatty tissue light green, necrotic core is red, and dense calcium is white, as you can see. Different color coding, so the different color coding gives us the idea about the plaque composition. Virtual histology IVAS has been validated in many studies which report excellent predictive accuracy for all tissue components, more than 90% with specificity ranges from 72 up to 99% compared with gold standard of the histology. These findings led to many trials examining the ability of virtual histology IVAS to predict MACE in patients according to plaque characteristic, namely VIVA in 2011, Prospect 2011, Atherosclerotic IVAS 2018. All found that virtual histology TICFA is an independent predictor of future MACE at 3 years. This is a pattern of TICFA as we see in virtual histology IVAS. Now we'll move with NIAS IVAS, considered as one of the multimodality intravascular imaging combining IVAS technique with the near-infrared spectroscopy, with the ability of detection of the presence of lipid-rich plaque within the same ballpark. The catheter itself combines two transducers, the transducer of the ultrasound transducer with two NIAS fibers for detection of the color coding. This is what we get from the IVUS image, NIAS IVUS image. As you can see the ordinary IVUS image with a color code, color mapping, and the longitudinal view. We can measure the main finding of the NIAS IVUS, which is called maximum lipid core burden index within 4 mm or max LCBI 4 mm. Several NIAS IVUS trials have been published since its first use in human 2010. These are the results. Main one are NIAS IVUS lipid-rich black study and prospect absorbed in 2020. The threshold of max LCBI 4 mm more than 400 was found to be associated with D-segment elevation in my culprit segments, with a sensitivity and specificity a little bit high. And there are several prospective studies demonstrating that high max LCBI is a strong predictor of the subsequent MACE, Oracle NIAS IVUS, and with future no reflow following BCI. Another study done by our group in Japan, utilizing NIAS IVUS to differentiate the etiology of ACS, either it's plaque rupture or plaque erosion and calcified nodule. It was published in the JAC. This is the findings correlating NIAS IVUS images with OCT images in the acute coronary syndromes. Finally, the OCT. This is the gold standard images to differentiate the black characteristics. Intercoronary OCT is a catheter-based imaging modality integrating a flexible optical fiber with an imaging lens capable of emitting signals at a wavelength 1,300 nanometer. By measuring this magnitude, it can give us the image we can see. The great spatial resolution of the OCT is 10 to 20 micrometer. Expert consensus document differentiate the different kinds of plaques according to the image. Fibrous plaque are shown as homogeneous high backscattering regions, while lipid-rich plaque are defined as signal-poor regions, diffusely bordered and overly signal-rich bands. While fibrocalcific or calcium is a signal-poor, also regions with sharply delineated borders. As you can see, number A is a fibrous plaque, high backscattering image. Number B is a lipid-rich plaque with diffused borders, and of course, thin cap fibroaceroma, and number C is a calcium. For the other images, this number D is a new vascularization, as you can see here. This is a macrophage accumulation, and this is a cholesterol crystal accumulation. Further, OCT is capable of measuring the fibrous cap thickness, which is the precursor of the TICFA, to define the vulnerable plaque, with a cutoff point less than 65 micrometers to define thin cap fibroaceroma, as you can see. Furthermore, new vascularization can be detected within the plaque, which is a marker of a rapid progress and plaque progression, as we can see again. This is a summary of the OCT role in the clinical practice. We can see use the OCT in many different modalities, like differentiate etiology of ACS and prediction functional significance of coronary artery disease, predictive risk of no reflow curve, evaluation of coronary calcification, evaluation of the risk of side branch. All these findings helpful during our routine BCI management of the patient. OCT can predict FFR significance where minimum lumen area less than 2.0 millimeter square predicts FFR less than 0.75, while MLA less than 2.5 millimeter square predicts FFR less than 0.8. TICFA is more commonly observed in lesions with subsequent no reflow, and in case of TICFA, long lipidic lesion or large lipidic arch, the risk of no reflow is increased. This is a summary for all available images in invasive imaging modalities and how they can assess differently the plaque characteristics. I was focusing on the areas, lumen area and plaque area, and percent atheroma volume and total atheroma volume, while virtual histology IVUS adds more to differentiate the characteristics or the composition of the plaque itself. OCT, of course, it gives us a clear image of the plaque component, and NIAS IVUS focus on the lipid content. Finally, a short talk about upcoming soon is the micro OCT. While the OCT resolution reaches 10 micrometer, they developed a new technology called micro OCT. The resolution will reach 1 to 2 micrometer, capable of identifying individual coronary endothelial cells. It can see cell by cell, with inflammatory cells, cholesterol crystal, vascular smooth muscle cells, fibroblasts, microcalcification, and components of thrombi, such as platelets, fibrin, all can be seen very clearly. Early trials in 2019, both in vivo and ex vivo, showed a very high degree of correlation between micro-OCT and scanning electron microscopy as a gold standard. This is the image we can see from 3D micro-OCT compared to the electron microscopy, very comparable images. Of course, it has a lot of limitation. It's a little bit under clinical trials, not available for clinical use. And the pullback speed is very short, very slow, and it needs more development to be incorporated in the clinical trials. So my take-home message will be, currently there are several imaging modalities available for invasive assessment. It's important to understand the strengths and weakness of each modality to select which is best for every individual patient. In the future, combining IVUS OCT or NIAS OCT in a single catheter will have more clinical implications and will help interventional cardiology even more. And thank you for listening.
Thank you very much. It's of course important to identify the vulnerable plaque invasively or non-invasively. But finally, if we find a vulnerable plaque, what would you do? For example, we know that most of vulnerable plaques are non-stenotic. So if it's, for example, 40% and it's vulnerable, what would we do?
Up to now, there is a lot of debate about this condition, but most of the trials come to the conclusion that we don't have to intervene for these vulnerable plaques.
This is very important because I don't want the idea of that we can see the vulnerable plaque that to be translated to go and study this vulnerable plaque, because this issue was discussed all ago. When they said that the concept of plaque passivation, they at a time they said that these vulnerable plaques should be stented to be stabilized. But now the concept is different because the vulnerable, if we can call it vulnerable passivation or stabilization of vulnerable plaques, is a medical process. Through statins, to control risk factors, diabetes, and so on.
A lot of lipid lowering or statin therapy can be stabilized.
This is extremely important. This is extremely.
It's back to the first lecture.
Yes.
It's better to spend money in stopping a train from reaching the final station rather than spending millions in imaging.
Shukran, Dr. Amir. Thank you very much. And now Dr. Islam Mashawi will complete the journey about the non-invasive assessment of vulnerable plaques. Dr. Islam, the floor is yours.
Thank you, Professor Dr. Wael Kilani, for coming this early for this session. Thank you for our guest, Dr. Jakime, for his excellent presentation. Thank you, Amir, for Okay. Can you send this ولا I will take the word from my friend Dr. Wael that most of the vulnerable plaques are non-stenotic ones. And I will say this in my lecture that invasive strategy for assessment of patients to detect the vulnerable plaque has already happened in high-risk patients. That's why non-invasive assessment of vulnerable plaque may carry more feature than invasive one, which is used only for high-risk patients. We know that coronary artery disease remains the largest single cause of death in the world. Traditionally, atherosclerosis management consists in detecting obstructive coronary artery disease. That's what we all do in coronary angiography, in CT, and in even non-invasive stress imaging. We would like to detect the flow-limiting lesion, which is usually above 50 or 70%. However, this paradigm is being challenged as the revascularization of obstructive coronary artery disease failed to reduce acute coronary syndrome events in recent studies. And most of these events occur on non-obstructive plaques. Evidence accumulated along converging lines of investigations indicate that acute coronary syndrome are due to activation of a vulnerable plaque. Traditionally, angiography has been used to detect atherosclerotic plaque in coronary arteries, and the degree of luminal encroachment by atherosclerotic plaque has been traditionally evaluated for management of coronary artery disease. However, it doesn't predict the clinical outcome, such as the likelihood of development of acute coronary syndrome, including sudden cardiac death. It has been found that plaques that are not significantly stenotic on angiography causes acute myocardial infarction. In Framingham risk study, more than 70% of patients having acute myocardial infarction, we having a lesion less than 50%. And the 85% of patients having acute coronary syndrome, they having lesions less than 70%. Neuroimaging and the diagnostic modalities are required to predict which of the atherosclerotic plaque are prone to rupture. An atheromatous plaque becomes vulnerable to rupture when a constellation of processes activated by various trigger mechanisms. To a varying degree, an atheromatous lesion is comprised of a high lipid core covered by a thin fibrous cap and plenty of macrophages and smooth muscle cells. More calcium, more stabilized plaque. So it's a high lipid core and the thin fibrous cap. This is the trigger of vulnerability and a marker of plaque vulnerability. Disruption of the plaque expression of thrombogenic materials leading to intraluminal thrombus. The vulnerability of a culprit plaque is determined by critical mass of a highly thrombogenic lipid core, thickness of the atheromatous fibrous cap, the thinner the fibrous cap, the more vulnerable the plaque, and the increased population of macrophages and the inflammatory cells. So it's not only the plaque, there is something in the myocardium also which makes the patients more vulnerable, and there's something in the blood, in the circulating blood. So it's better to express or to say the expression of vulnerable patient rather than vulnerable plaque. And this will take us directly to controlling risk factors such as increased lipid level, diabetes, hypertension, etc., smoking, which will more control vulnerable plaque rather than just concentrating. And we heard from Amir the invasive techniques for evaluation of the vulnerable plaque. But some of the features of vulnerable plaque can be identified with invasive imaging techniques, as Amir mentioned, but cannot be translated to routine clinical practice because of cost and due to the fact, which is very important, this is most important fact I'm going to say, that invasive techniques such as OCT and IVUS, as Amir mentioned, cannot be employed in a large population and are restricted to patients previously identified as high-risk patients. Not everybody do coronary angiography, and even not everybody else doing IVUS or OCT. Improvement of multimodality imaging techniques of the plaque allow non-invasive visualization of this technique. So what we have, magnetic resonance imaging holds the promise of non-invasive imaging of high-risk patients, plaque, experimentally in a small hypercholesterolemic animal model in atherosclerotic lesions. An excellent agreement was observed between MRI and histopathology. MRI currently being used to study the progression and regression of atherosclerotic plaque over time. However, it's not free of limitations. MRI lacks sufficient resolution and will have several limitations: the long time of acquisition, the claustrophobia, and the devices which may prevent us from evaluating most of the patients. So nuclear imaging actually having a very excellent present and future for imaging the vulnerable plaque, because we know that in vulnerable plaque there is a previous inflammatory infiltration of the fibrous cap, a lot of macrophages, and this is the target for nuclear imaging by PET imaging using FDG. This is the plaque that are vulnerable to rupture. It had a thin fibrous cap and a lot of macrophages within. These macrophages predominantly apoptotic and are associated with intense melanoproteinase upregulation that contribute to diagnosis of matrix and digestion of matrix and fibrous cap rupture. Since inflammation is the most important component within this equation, diagnostic targeting strategies should identify macrophage predominance in the plaque vulnerable to rupture. PET imaging using FDG has been used extensively in humans to detect inflammatory activity associated with neoplasms in oncology field, autoimmune diseases and infection. PET FDG is well-tolerated technique that can detect changes in inflammatory response in therapy. And studies have demonstrated enhanced FDG uptake in inflamed blood vessels, like in aortas with balloon injuries, cholesterol-fed rabbits, disease associated with vessel wall inflammation like Takayusu, giant cell arthritis, and non-specific aortitis. So if the invasive imaging techniques are not able to detect this previous inflammatory infiltration of the fibrous cap, as you can see on the right side of the slide, the FDG, which is a hot image, diagnosed that plaques with a high macrophages, is very easy to detect. Multi-slice CT actually also is one of the techniques which we can use to evaluate the vulnerable plaque. First of all, the calcium score. Detection of calcium, it doesn't reflect either the stenotic lesion or vulnerable lesion. But the higher the amount of calcium reflects clearly the burden of atherosclerosis. If you have a high calcium score, so the burden of atherosclerosis in this patient is high. I'm not saying again that presence of calcium means a stenotic lesion or vulnerable lesion, but the higher the calcium, the more the burden of atherosclerosis. In most coronary CT studies, the plaque are classified into calcified, non-calcified, which is soft, no calcium, and mixed. Calcification is defined for density greater than 220 Hounsfield units, and the lesion with 50% or greater calcium are calcified, as calcified, and less than that as mixed. Obviously, this calcification is too simple to describe the complex composition of advanced plaque. Several investigations have recently attempted a more detailed assessment of coronary plaque in symptomatic patients. In CT studies, ring-like attenuation ring in the non-calcified portion of the non-calcified or mixed plaque is described as a suggestive of high-risk plaque and higher likelihood of acute coronary syndrome. Some features of the plaque in the CT can detect the more vulnerable one. One of them, the ring-like attenuation. This attenuation pattern also known as napkin ring, and we're going to see some of the examples. This pattern is seen in 8.5% of examination and equally described in both mixed and the non-calcified plaque, not in the purely calcified plaques. This is the napkin ring, like if you're having a ring in your hand, and this phenomena, usually we see it in patients with acute coronary syndrome, the napkin ring sign in CT. And there are several studies correlate between the culprit plaque in thick cap fibrous atheroma plaque according to OCT criteria, and compare the results with the CT finding, and they found a lot of agreement between the CT napkin ring appearance and OCT detection of vulnerable. Other associated imaging finding in vulnerable plaque are positive remodeling and spotty calcification. And we will have some figures for this spotty calcification, not pure calcium, not purely non-calcified plaque, but there is a spot, small calcium within the non-calcified plaque reflects more vulnerability. Like in this image, you can see some small spotty calcification, which reflects the vulnerability of the plaque, which is more vulnerable than purely calcified or purely non-calcified plaque. So the most vulnerable plaque in cardiac CT are those having large non-calcified core with a small spotty calcification within, or those having napkin ring appearance. So in conclusion, plaque composition rather than the degree of stenosis determine the risk of acute coronary syndrome. Angiography has limited role in identifying vulnerable plaques, and all invasive techniques also having its limitation. MRI has an excellent utility in visualizing plaque and discriminating its component, and can soon become the gold standard. FDG PET imaging shows promise for the detection of inflamed atherosclerotic plaque. CT offers an interesting new option to non-invasively detect, quantify, and to a certain extent characterize coronary atherosclerotic plaque, as we mentioned, calcified, mixed, and non-calcified. However, CT characteristics of coronary atherosclerotic plaques remains challenging and require optimization of image quality. Further technical improvement regarding data acquisition and reconstruction, as well as increasing number of prognostic and outcome studies, is needed to validate the use of CT in assessment of vulnerable plaque. Thank you very much for your attention.
Thank you, Dr. Islam. A very important lecture as well. Again, the assessment of vulnerable plaque and to know the degree of vulnerability of these patients puts the patient in his risk scale. So if he is high risk, so you should be much more aggressive regarding the antiplatelet therapy, regarding the lipid lowering therapy, and so on. And this does not mean to go directly for angiography. Angiography is a different issue. So vulnerability does not mean stenting. Sure. Any questions from the floor? Thank you very much, Dr. Islam. Very good. Okay, sir. Mike, يا جماعة.
However, it's beyond the scope of my talk, but I think colchicine is one of the suggested medications which have been prescribed for patients with acute coronary syndrome, and its main role, I don't have any idea about the role in colchicine in stabilizing the vulnerable plaque, but maybe I need to search about it.
Sorry. Thank you for your elegant lecture. Does we need imaging for detection of the vulnerable plaque for every patient with ischemic heart disease, suspected ischemic heart disease, or what is the break detectors that we can benefit from this evaluation?
Another excellent question, and as I mentioned, the invasive techniques is restricted already for high-risk patients. And in those patients, I don't know if you define the patient already as high risk, is it costly to do all those sophisticated invasive imaging to detect it is vulnerable or not? I don't know the answer for this question. But the value of non-invasive imaging is that it's applied for a large scale of patients. We send sometimes very low-risk patients to non-invasive imaging, to CT, to MRI, and by doing so, you have the ability to detect some vulnerable patients, I'm going to say, rather than vulnerable plaques. And I have never ever write in my comment, and even it's not in the guidelines anywhere, that you write in your comment that in CT that this patient having vulnerable plaques. But you say that it's non-calcified plaque, and your aim is to conduct a message to interventionists that if you are going to do intervention for this patient, take care that this is a calcified lesion, this is a mixed lesion, or this is non-calcified lesion, to make the intervention easy. But putting this into the report is not yet recommended, rather than in any guidelines. So I think the non-invasive imaging carry the potentiality or carry the promise to image more patients, and you can include moderate to high-risk patients for those. And I think it needs more research to make it applicable and to make it easy.
Can we say that these tests can, if it's okay to say that these tests can risk stratify or can be added to the risk stratification process, so that we can put the patients, for example, if we think that he's low risk, if we do one of these tests, can we reclassify the patient as high risk or very high risk? Do you have data about this?
This is right. This is right comment. And let me tell you one of the just personal finding. When we have acute imaging, like in the emergency departments, when they have a patient with acute chest pain and we have a lesion, we found those signs, as I just mentioned in CT, we see the napkin ring sign, we see spot calcification, and it needs more investigation and registry. And this tells us that this patient really having acute coronary syndrome. So we have these findings and we see it in clinical granulum. So it can help in risk stratification indeed, Dr.
Okay.
Well.
Any more questions? Thank you very much. Dr. Islam, a very comprehensive lecture. Thank you. And now Dr. Mohammed Rida, borderline atherosclerotic plaques in non-culprit coronary artery lesion. Is it dangerous?
Next. Back.
Bismillah ar-Rahman ar-Rahim. It's a great pleasure to give my lecture in such a prestigious conference like CardioEgypt, and this lecture will answer many questions that you already asked in this session. So we'll start with the borderline sclerotic plaques and non-culprit coronary artery lesions. Are they dangerous or not? My agenda would be the impact of non-culprit plaques, the vulnerable plaque concept, assessment of vulnerable plaques. Of course, in short, it has been expertly explained by my professors, and future directions and management options. Why it matters. Multivessel disease has typically been reported to be present in 40 to 50% of patients with acute myocardial infarction in both institutional registries and multi-center clinical trials. Multivessel disease also associated with higher Caleb class, lower baseline left ventricular ejection fraction, less frequent involvement of the left anterior descending artery as the infarct-related artery of presentation. As we can see in this graph, effect of multivessel disease and mortality, it gives a huge difference between single vessel disease, which predicts 3.2 risk of development of death at 1 year, with triple vessel disease rising risk up to 7.8% of 1 year mortality. So for the vulnerable plaque itself, when ruptured and complicated by thrombosis, the cholesterol-rich lipid core atheromas are strongly associated with myocardial infarction and cardiac death. And these coronary events lead to the concept of development of so-called vulnerable plaque, defined as non-obstructive lesions that are at elevated risk of rupture. Actually, it is not a recent subject. It has been extensively studied since the 80s, proposed in the 80s, to describe plaques that were liable to rupture and triggering coronary events. And the pioneer in this field is Dr. James E. Mueller, who was an American cardiologist and studied extensively the vulnerable plaque. Features of vulnerable plaque. Is any plaque that we found with high lipid-rich content, is it dangerous or not? We have 4 main features: the presence of thin-capped fibroatheroma, plaque burden of 70% or greater, minimal luminal area of 4 square millimeter or less, and a combination of these characters have been characterized as a high-risk feature. As we can see here, the presence of a thin-capped fibroatheroma alone is associated with higher risk of MACE of about 5% that increases with additions of other features to reach 18% when all the 3 features are present. In autopsy studies, vulnerable plaques had a specific phenotype showing a high plaque burden and a large lipid core. And rupture of plaques with high lipid content causes the majority of adverse coronary events, of course, like myocardial infarction and death. So lipid content in the coronary artery is represented by the max LCBI, as explained by my colleague, Dr. Amir. A lipid-rich study showed that at a pre-specified value of 400, max LCBI of 4 millimeter is a reasonable predictor for subsequent events for the patient and plaque levels. As we can see here, there's a higher risk, of course, when the max LCBI exceeds 400. How to assess vulnerable plaques, that has been extensively and expertly explained by my professors, by Professor Islam and Dr. Amir. So it will be such a glance. IVUS, of course, to determine the plaque burden, near-infrared spectroscopy to assess the lipid content, optical coherence tomography to assess better the fibrous cap thickness, and chronic computed tomography angiography to assess the napkin sign, as mentioned by Professor Islam, and as well as other new measures like the PET and MRI to assess the inflammation of the plaque itself. Future direction and management options. Is there a role for interventional treatment and management of vulnerable plaques? Don't shoot the messenger. Yes, there is. We have medical management and interventional management. Of course, medical management has still the upper hand, as a recent meta-regression analysis showed that a 1% reduction in mean percentage atheroma volume induced by dyslipidemia therapies was associated with a 20% reduction in the odds of MACE. So there have been multiple clinical trials explaining the role of medication and medical management in vulnerable plaques, starting from the YELLOW trial, IBIS-4 trial, Glagov's trial, Pacman AMI trial, and Hawkins trial. In YELLOW trial, it was the first one in 2013, showed potential influence of medication. It was 87 patients with multivesic coronary artery disease and with PCI to a culprit lesion and at least one other non-culprit lesion, which was obstructive with a fracture with FFR less than 0.8. Compared the intensive versus standard of care lipid lowering therapy for 7 weeks, and endpoints were the changes in the max LCBI within the 4 millimeter maximum segment. It concluded that short-term intensive statin therapy may reduce lipid content in obstructive lesions. In IBIS-4 trial, it was on 100 patients, and they performed IVUS and OCT on 2 non-infarct-related coronary arteries in acute phase of STEMI, and given them rosuvastatin for 13 months. It was found here that there was a change in the minimum fibrous cap thickness with the high-intensity statin given for 13 months. Increase, of course, and this increase was more pronounced in patients with thin cap fibroatheromas compared to other plaque phenotypes and non-culprit lesions. Then it was the introduction of the PCSK9 inhibitor, and it was the Glagov trial in 2016. It was a multi-center trial of 968 patients, including non-significant plaques, comparing the use of vivolocumab versus placebo for 76 weeks plus statin therapy. And addition of vivolocumab to statin therapy resulted in greater reduction of the percentage atheroma volume after 76 weeks of treatment. And as we know, every 1% reduction of percentage atheroma volume lead to more decrease in the risk of MACE, with also a greater percentage of patients with regression of the plaques in patients who received statin plus PCSK9 inhibitors. The Pacman AMI and Hawkins trial provided more evidence for the use of PCSK9 inhibitor. As we know, in the Pacman AMI trial, it was 300 patients, recent trial in 2021, and they performed IVUS, NIRS, and OCT of non-obstructive plaques, comparing the use of alirocumab addition to high statin therapy versus placebo, and showed that significantly greater coronary plaque regression after 52 weeks, and that was established by reduction of percentage atheroma volume, reduction of the maximum lipid core burden index within 4 millimeter, and an increase in the minimal fibrous cap thickness. So stabilization of the vulnerable plaque, actually. In Hawkins trial, it demonstrates mean increase in the minimal fibrous cap thickness with evolocumab among 135 patients with non-ST elevation myocardial infarction. So interventional management, is still a role of interventional management or not? Yeah, there is the study named the debut LRP study that was local. It studied local preemptive percutaneous treatment of lipid-rich plaques with a paclitaxel-eluting drug-coated balloon. It may be a novel therapeutic strategy to prevent future adverse coronary events without leaving behind permanent coronary implants. It's still a pilot study, testing the safety and feasibility of treatment. And the endpoints will be at 9 months, the change of max LCBI within 4 millimeter in drug-coated balloon-treated lipid-rich plaques. And secondary endpoints will include the clinical adverse events and IVUS-derived parameters like the plaque burden, like the minimal luminal area. And clinical follow-up will continue until 1 year after enrollment. So again, borderline atherosclerotic plaques in non-culprit coronary artery lesions, are they dangerous or not? I'll give this final example to emphasize my point. The answer is yes, actually, because as we can see here in this patient, there was a stenting in the mid RCA, shown by the blue bracket showed the stent margins, and the white brackets showed a mild stenosis in the proximal RCA. If we all see it during catheterization, we will not notice it at all. We are talking about 20 to 30% plaque, nothing more. But when NIRS was performed to this patient, it revealed the presence of a large lipid-rich plaque with a max LCBI of 694 at the site of this mild stenosis, as shown by this white box. And 7 months later, this patient presented with a non-fetal acute coronary syndrome with the de novo culprit lesion of the proximal RCE at the same plaque site that was shown before. And during baseline, IVAS assessment of this patient showed, like Dr. Amir showed in his lecture, we have a large plaque, high lipid content, but it's not stenotic. It's not stenotic at all. So my take-home message would be the non-culprit plaques may be responsible for future MACE. The vulnerable plaque concept lead to extensive research, increasing our data about the features of high plaques and how to modify them. The lipid-lowering therapy has been proved to improve features of non-culprit plaques and decrease the risk of future MACE. Other options like prophylactic local intervention with drug-coated balloon are still currently under research. And thank you for your attention.
Thank you very much. A very nice lecture. Well, of course, we are. I myself am very excited for the results of this trial, trying to use a drug-eluting balloon for stabilization of plaque. Will it really work or not? Again and again, vulnerable plaque. It's important to know that this patient, as Dr. Islam said, is vulnerable and he has vulnerable plaques. But how to manage is still a matter of debate. Thank you very much. And by now we close this session. Thank you very much.